Hi, thanks for watching again. This is the Doctor Podcast Show, episode number 82, and I'm your host, Dr. Robert Cykiert. Today, we're talking about a very important topic, which is in the news a lot lately, and that is colon cancer. There seems to be an increased number of cases of colon cancer in recent years, and it seems to be happening in younger people. So today we have two excellent expert guests to discuss colon cancer and learn about the latest techniques for diagnosing it and helping to treat this cancer. Our first guest is Dr. Andrew Albert. Dr. Albert is board certified in gastroenterology and also internal medicine. He practices in Chicago at the Chicago Gastro Practice. He's a clinical assistant professor of medicine in digestive diseases and the nutrition department at the University of Illinois at Chicago. Our second guest is Dr. Craig Eagle. Dr. Eagle is a hematologist-oncologist. He's the chief medical officer of Guardant Health Company, which is a precision oncology company, which we'll talk about what that means, a precision oncology company. Prior to that, Dr. Eagle was also in the oncology divisions of Genentech and Pfizer, both large pharmaceutical companies. So thank you very much, both of you, for taking time from your busy day to join us today. I really appreciate it. Dr. Albert, I'm going to start with you. I'm going to ask you a couple of questions. According to the latest data from the CDC in 2021, colon cancer or colorectal cancer was the fourth most common cancer in the USA, with about 142,000 cases reported annually. And unfortunately, there's about a 35% mortality rate. So that's about 52,000 people that died that year. Also, there's been about a 15% increase in colon cancer in people under age 50 in the last 20 years. And this year, I'm told there are about 18,000 new cases in people under age 50, almost an epidemic. Can you tell us what colon or colorectal cancer is and what causes it?
Sure. Thank you for the question. So, as you stated, colorectal cancer is a major health problem. Colon cancer impacts about 1 in 23 people, as many of you know. Colon cancer is a tumor within the colon, usually derived from a polyp, which is dysplastic tissue that arises spontaneously within the colon. Once that polyp, which is a low-grade dysplastic lesion, continues to grow and grow without being removed, it will one day, through various methods, turn into a high-grade dysplastic lesion, carcinoma in situ, and ultimately a colorectal cancer neoplasm. The problem with the colon cancer is that it will grow within the lumen or the tube of the colon, but will also grow through the wall of the colon, spreading to other areas, including the lymphatics, the blood vessels, and with local spread. With early detection, colorectal cancer is very treatable, which we can get into later. As far as the rise in colorectal cancer, which by 2030 is expected to be the #1 cancer in people 25 to 49 years of age, the causes of this we think are secondary to potential obesity, which is a rising health issue. There is some potential correlation with microplastics, but mostly obesity and processed foods are the two most common potential causes of this dramatic rise that we're seeing.
Right. Now, is it also familial or genetic? Does it run in families?
So there are two particular colorectal cancer genetic aberrations. One is familial adenomatous polyposis, and another is Lynch syndrome. Those we know. So those are genetic. There are the environmental exposures as well, but those are two of the main ways that we see colorectal cancer occurring beyond just sporadic incidents.
Right. Now, you mentioned obesity as a risk factor. We're seeing obesity as a risk factor for many diseases, diabetes, heart disease, dementia, etc. How does obesity cause cancer, though?
It's a really good question. There's thinking that potentially, and I'm not a scientist in this specific area, but the extrapolation is that the estrogen levels associated with the obesity might be growth factors within or cause a colorectal cancer to grow beyond what it typically would. So I think exposure to certain hormone groups that are higher in obese patients will lead to an increased likelihood for colorectal cancer.
I see. And what about alcohol use? I know alcohol increases the risk of upper gastrointestinal cancers. Does it also increase the risk of colon cancer?
For sure. So alcohol and tobacco are both good or strong influencers as it relates to colorectal cancer development. Sometimes with polyps, which are low-grade dysplastic lesions, there's another hit, as we say, right? The two-hit hypothesis, and there is a second hit by a toxic exposure like that with alcohol or tobacco. And those two have already been known to be causative factors in colorectal cancer development. Unfortunately, that use continues in significant ways as we have newer ways of using those products. And so I foresee that being a problem in the future.
Right. Now, we talked about the fact that it's occurring in younger and younger people. I'm seeing that in the media all the time. Is there another explanation for why that's occurring, why it's spreading to younger people? It used to be just people in their 50s, 60s, and beyond.
Yeah, I mean, I think we're moving away from that. I mean, we're seeing colorectal cancer in people as young as 16, 18 years old.
Really? Wow.
There's definitely a thinking that perhaps younger people have exposure to processed foods. There's also a theorized possibility that antibiotic use in higher levels, that the frequent use of antibiotics in younger people at younger ages could perhaps influence the development of altering gut bacteria or gut, the biome, if you will, or the gut flora. I
Right.
don't know that we know exactly how that looks, but I know that that is a factor being considered in the development of colon cancer in younger people.
So if you take antibiotics, you're killing off certain bacteria, and then other bacteria grow in their place, and maybe those are harmful or toxic to the colon and then trigger this cancer.
So I think the way to think about that is that there's good bacteria and bad bacteria. And when you are treating the various infections, you're killing the good bacteria that balance. So for example, in C. diff, when you're using antibiotics, you're killing the good bacteria and then C. diff flourishes. In the same way with colon cancer, certain bad bacteria might make toxins that sort of exacerbate the development of a colorectal lesion. And so the thinking is that maybe the antibiotic use in younger years might sort of expedite that process a little bit or select out the bad bacteria with toxins that could actually worsen or increase the risk of colorectal cancer.
Right. So knowing this information, at what age should people start screening or being tested for colon cancer?
So, as you know, the guidelines for colorectal cancer screening were decreased to the age of 45. And that was because of a significant, I believe it was 12% increase in people having colon cancer between the age of 45 and 50. So, as a result of that sharp increase in colorectal cancer cases in younger people than 50, the age was lowered to be average screening at the age of 45. Unfortunately, because we're seeing this rise or expected rise by 2030 of younger people, I anticipate that the screening age will be even lower in the years to come.
And screening is basically getting colonoscopy. That's the benchmark or gold standard currently.
So that's a great question. So colonoscopy has always been the gold standard for colorectal cancer screening. But as we know, patients want choices. And as a gastroenterologist, I'll be honest and say that it's most important that we screen patients however possible. It's impossible also to screen everybody with a colonoscope because how many procedures can you do in a day? And
Right.
so I often say, and we often say the best test is the one that gets done. So whether it's a stool test or a blood test or a colonoscopy, in my mind, it's about getting the test done because 1 in 23 people is way too many people to get a mostly preventable malignancy.
Right. Now, what are the symptoms of colon cancer that people should look for? And if they get them, see their doctor right away?
So it's a great question. So the most common symptom of colorectal cancer is no symptom at all. we say that oftentimes patients have colorectal cancer up until stage 1, 2, or 3, and they don't actually know that they have it until they have the more advanced form, which is bleeding or pain or constipation or change in bowel habits. So the symptoms that we see with colorectal cancer typically indicate a more progressive state of colorectal cancer. So in all truth, really, the most common symptom is no symptom. However, sometimes people will demonstrate some bleeding or some abdominal discomfort that is oftentimes sort of passed over and sort of, patients wait or delay. But any symptom that's different, we say, any symptom of pain, bleeding, altered bowel habits, weight loss, change in appetite, any of those symptoms that are new for you as a patient should always be evaluated by a gastroenterologist or a primary care doctor for that matter.
So anything that changes, if it persists more than a short period of time, get it checked out.
Correct.
Now, Dr. Eagle, we mentioned that colonoscopy is sort of the benchmark or gold standard, but we also mentioned that people don't necessarily want to get that because they're afraid of it, and also the prep for it is not pleasant. Why is it that, other than those two reasons, why is it that people don't get screened for colon cancer? I'm an ophthalmologist. I have many elderly patients who tell me they've never had a colonoscopy, and I tell them they really need to get that. Why don't people get colonoscopies?
So I think to the points that you raised, colonoscopy requires some degree of prep time. In that prep time, often it means you can't do your usual activities over the preceding 2 or 3 days for that. It's often resulting in excessive bowel movements and diarrhea, if you like, as you clean the bowel out. And then there's the procedure itself, just the thought of having a colonoscopy with the sedation and the scope. For a lot of people, this becomes something that they would rather avoid or prefer not to go for. So then you look for non-invasive type testing for screening. And so that's then a stool-based test, which is another alternative. And that becomes something that then you have to collect and handle your stool. And a lot of people don't like doing that. Often it's often referred to as the icky or yucky factor that have to deal with all that. And so these are all multiple reasons. And when you step back and look at a screening, we've been screening for colon cancer for some time now, and it's still the second leading cause of cancer death in the US. And we've, despite a lot of effort from a lot of people and a lot of organizations to encourage that screening of colonoscopy or stool testing, we're only hitting about the 60% mark of people getting the screen. As you mentioned, like the patients you're talking about, there are a significant number of people that don't continue to get screening. The other thing to keep in mind about screening, it's a commitment over a lifetime from age 45 and beyond for the average risk person. So it's not just a one test and done. You've got to repeat it several times, depending on which way you use it. And so a lot of people have it once and then don't want to come back after their experience, for example. And so it's, again, part of the reasons people don't get the testing.
Right. On the other hand, if you get tested and screened, if you catch it early, my understanding is that it's very treatable, and the success or prevention of metastases and death is significantly reduced. So early finding is very important. Isn't that right?
That's right. And again, as Dr. Albert mentioned, colon cancer is one of those cancers that we're very fortunate to understand the process. There's precancerous lesions, what are called advanced adenomas or polyps, if you like. Then there's the early stage of cancer where it's still localized in the colon and where it's that relatively asymptomatic stage. And then there's the more advanced stage where it spreads. When you look across the board, getting the polyps early helps prevent the cancer occurring in the first place. On the other hand, if you catch it in that very early stage when it's still in the bowel wall, what we term as stage 1 or stage 2 of cancer development, you can get survivals upwards of 91%.
91,
However,
that's huge.
it's fantastic to catch it early. However, if you miss it and it comes out later and you get it when it's more that late stage, stage 4, symptomatic stage, your survival drops all the way down to 13% for that. So this is a huge motivator to say, let's get it early, let's prevent it early and detect it early, because survival is really high.
Right. Because once it's spread, you need both surgery and then chemotherapy, and you have side effects from that as well.
Right. And the 13% is the 5-year survival rate, basically. So it's very dismal outlook at that stage.
Right. Now, I mentioned earlier you're the chief medical officer at Guardant Health, which is a precision oncology company. Can you explain what that means, precision oncology?
Yep. So one of the things that's very important, we believe, is that to help anyone with cancer, the more you understand the cancer, the more data you have about your cancer, and even about the data across multiple cancers, the more chance you have of controlling it and fighting it, with the ultimate aim to give people more time with their families, friends, and so forth. And so one of the things we do is look at the precision through various blood tests, tissue tests, uh, real world analytics, for example, using artificial intelligence and other means to provide as much data to the treating physician or the oncologist about that person's cancer. So that way then they can choose and select the precise treatment, hence the word precision, to give the person the best chance of the time factor. So this is how we focus our efforts, is data lead to precision, which gives people more time.
Right. Now, can you tell us about a liquid biopsy as compared to a surgical biopsy where you have to make an incision into the tissue? What's a liquid biopsy?
Right. So a liquid biopsy is basically a blood test that picks up fragments or parts of the cancer. So all tissues in our body grow and shed the fragments of that growth of the tissue into the bloodstream. And cancer is no different. Quite the opposite. Cancer is often more frequent. Cancer is often caused by a very focal area of damage to the DNA and the genes. And so that's unique, because that's unique to the cancer. And as that cancer grows and sheds into the bloodstream, we can pick it up. So a liquid biopsy picks up the DNA or genomic aspects of a cancer. Of course, the other way to get it is to go directly to where the cancer is itself, and that's the tissue biopsy or the surgical biopsy. So if you see the cancer, you can go take a sample of that and actually test it for the same genetic makeup. With that, of course, as you rightly point out, the word surgical implies to get to these cancers, you need to have surgery and you need to get to where the cancer is located. With a liquid biopsy, it's a blood test. No different to you have a blood test for other things like cholesterol or diabetes. It's a simple blood test to capture that same genetic information that would occur from the cancer.
Right. And a blood test is zero risk, basically, and no downtime. So
Right.
that's very important. Now, Guardant makes several different liquid biopsy products, and can you tell us about those, and specifically the Shield blood test that's used for colon cancer detection?
Yeah. So as I mentioned, we're trying to get as much data about the cancer through that cancer journey. And so we'll start at the other end where it's the more serious and advanced end. And as we talked about, we've got a blood test that looks at the genetic damage or mutations that occur in a cancer at the advanced stage, guiding that precision treatment. And so this is a test we have available to provide guideline-driven treatment choices. Of course, the next thing you want to know is that cancer responding to treatment? So we have a blood test that looks at the more advanced stage where you pick out the genetic mutations within the cancer itself, and you end up being able to precisely define the treatment and the therapy. Of course, at that point, you want to think about, is that treatment working? And so we have another blood test that then can look at and measure the response to that therapy, as well as then a blood test that looks at, if the cancer can't be found anymore, is there any residual amounts left or is there any chance of relapse? So that's sort of the oncology space. It's therapeutic choice and precision, along with very careful molecular monitoring, all from a blood test. Add to that, we've also got the tissue testing. So that way, if you need to use the actual biopsy, the surgical biopsy we talked about, we can also perform that testing. Finally, we move earlier into the stage of cancer, which is the prevention end, that very early point of cancer development. And this is where the Shield test comes in. And this is focused on colorectal cancer, where we're aiming to pick up in people in the blood, those that are developing the first changes of colon cancer. And that's coming from the blood test to signal that you need to now go and get further testing. In this case, it'd be a colonoscopy to confirm the test results and then get it early as possible.
Right. So that's the Shield test. It picks up
Yes.
the colon cancer. Is that approved by the FDA?
Yeah, so Shield got approved by the FDA in July of this year, 2024.
Oh, just a few
And
months ago.
yes. So we're
Great.
very excited by that.
What is it that the Shield test looks for in the blood? Is it DNA, mutated DNA, or some proteins that are produced by the cancer cells, or both?
Yeah, so it's a what we call a genetic or genomic based test. And as a cancer grows, it taps into the genetics of every cell and uses those genetics in different ways to grow as a cancer. And it's that differentially use of the genetics, or what we call differentially methylated regions, that the Shield test detects. So when people have colon cancer, the cancer cells of the colon are using different parts of the genetics, the DNA, and we can look at what's switched on and what's switched off through a process called methylation. And that switching tells us that there's cells in the colon that are now using this DNA in a way that is not healthy and reflects the cancer.
I see. Now, is the Shield test for low risk patients or high risk patients, or anybody can get it?
So the Shield test is approved for average risk patients over the age of 45 for screening for colon cancer.
So anybody over 45 can have it.
So yeah, exactly. So Shield test is a prescription only test. So you have to see your doctor and they will prescribe the test. But effectively, it can be used as a choice in colon cancer screening. Of course, we always recommend that the choice of type of screening suits what the patient prefers, as we talked about. And so, as was mentioned by Dr. Albert, the best test is the one that gets done. And now Shield adds to that flavor of choice for the physician. And through prescription, anybody can get the test done if they're over the age of 45, an average risk.
So, Dr. Albert, going back to you, what if a patient's 30 years old and their aunt or uncle or grandmother had colon cancer and they're really nervous about it because they've seen all these articles about cancer in young patients? Can they get the Shield test even though they're 30?
It's a great question. So people with a family history of colorectal cancer need to have the discussion with the gastroenterologist. And if they do have two secondary relatives or one primary relative who had colorectal cancer, they're considered higher risk and therefore would require a colonoscopy. Unfortunately, in that scenario, Shield cannot be applied because colonoscopy would be necessary for a higher risk population.
I see. Well, what if somebody's 35 years old, there's no family history, they're healthy, they're just freaked out by the data and articles they're seeing about colon cancer in young people? Why can't they have that test?
It's a great question, and it's ironic because I do get these questions quite a bit. Unfortunately, I believe that the FDA approval is based on the age of 45, and I'll let Dr. Eagle speak to this, but I believe the indication is that it is for patients 45 and over of average risk. So
I
I
see.
don't think it applies to younger people. If younger people do have risk factors, yes, we could consider colonoscopy or a guaiacing stool, but I don't think Shield would apply in that scenario. But that's a question we get quite often.
Right, because it would be an off-label use. If a 30-year-old who has no history and no risk factors wants the blood test, it is an off-label use of something that's approved by the FDA, so they should be able to get it if they want it.
That's a very tricky conversation, which we could certainly have. I mean, there is an out-of-pocket
I see.
cost they could, I'm sure, pay for. I don't know logistically how that works.
Right.
But certainly we will be getting a lot more of those questions as younger people are more
Yeah.
aware.
Yeah, especially because it's zero risk to get a blood test, basically.
Yeah.
What's in your experience, Dr. Albert, what's been the acceptance of this test? Or people say, oh, yeah, wow, that's great. Let me have the blood test. Or are they worried about getting the test because of what they may find out?
So I was hoping you'd ask that question. We are very excited about the availability of the Shield test for colorectal cancer screening for a multitude of reasons. Uh, Obviously, gastroenterologists love doing colonoscopy, but the truth is that many people do not want a colonoscopy, and this is a fantastic option to offer patients who don't want a colonoscopy. I think having walked the streets of Chicago, offering fit tests, which are the stool tests, with a response rate of as low as 10%,
Right.
but the adherence in a blood-based test like Shield being 90%, I think that this is a very welcome addition because patients do not want to do poop tests or stool tests, as they call them. They would rather have a blood test. And the
Right.
accessibility for having a blood test is a really big addition as far as getting compliance because patients go to the lab, they see their doctor. It's obviously easy, but doing a stool test requires a lot of anticipation. The, as Dr. Eagle said, icky feeling of having to do stool, carry stool, put it in the post. That's sort of an older option, but I'm excited about the newer option of having a blood-based test.
Right. Now, if somebody meets the criteria, let's say they're 50 years old and want to have it done, is it usually covered by insurance like Medicare or the other private insurance companies?
Yeah, you're talking about the Shield test, correct?
Yes, the Shield test.
So, Dr. Eagle, please weigh in. But my
Yeah.
understanding is that it is covered by Medicare Part B. Medicare Advantage patients might have a small copay. Commercial insurances are still pending, but that should be changing very shortly. And updates to the task force guidelines will also be changing as well as Shield becomes more ubiquitous throughout our practicing continuum, if you will. Dr. Eagle,
Right.
did you want to say something to that?
No, spot on, Dr. Albert. That was exactly where it is, covered by
That
Medicare.
that's accurate. So, Dr. Albert, how fast does a patient get the results from that blood test? Like if they check their cholesterol or blood sugar, it's available in 24 hours. How long does it take to get these results?
So this is a very highly specific and well done, thorough exam in the blood. So this requires up to 2 weeks.
2 weeks.
A conversation then ensues on the patient's having a colonoscopy to follow a positive result. You had asked me earlier, and I had failed to respond to this because there's so much to say. But the patients typically are very willing to have a colonoscopy to follow a positive Shield test. You might also be asking if patients have a negative test, when the follow-up would be, and that would be about 3 years for a follow-up Shield test after a negative one. But patients have been pretty responsive with getting a colonoscopy after a positive result.
Right, because they know then they have that risk, so they're willing to undergo the colonoscopy.
Yeah.
Um, Now, if a patient, let's say, still doesn't want to have a colonoscopy and they have a positive blood test, what do you do then?
So if a patient has a positive Shield test, then we would make the recommendation for a colonoscopy, and that would really be the next step. I mean, you could consider imaging, but imaging is not very reliable, and which is why it has never really taken off as an option for us in colon cancer screening. So ultimately, really, if the Shield test is positive, really there is only one other option, which is a colonoscopy
Colonoscopy,
to verify and diagnose.
right. How do the results of the Shield test compare to the Cologuard stool sample test, which has been around for, I think, 5, 6 years or something like that?
So the range of positivity or sensitivity rather in patients for non-invasive testing for colorectal cancer is around 74 to 92% for all methods combined. And I believe Shield is right in the middle of that range. The important thing to think about is not so much what the sensitivity is of the test, but really the adherence or the compliance in getting the test done, because really
Right.
the stool testing as low as 10% return for a fit test is still very low. 10% of 100 patients is still 10 patients
Right.
who might otherwise 90% are not diagnosed. So I think it's important to think about really the adherence, if you will, of the test, which in this case, I'm excited about the Shield test just because I've literally walked the streets of Chicago giving out fit kits and in my office and in my clinic offering up, alternatives. And unfortunately, the rate of return has been sadly low across the board in all stool tests. So we're very excited in the GI world to have another option that's reliable.
Right. If a patient has a negative Shield test and a negative Cologuard test, yet they're at high risk of colon cancer because of family history, let's say. Can they be assured that they don't have colon cancer if they have both of those tests and they're both negative?
We feel pretty good, or actually very good, about any of those tests being negative. The follow-up, though, is always going to be 5 years with a negative test, as patients with colorectal cancer in their family history are considered higher risk. Technically, in a higher risk patient, you would want colonoscopy, but the testing in that situation would be every 5 years. So.
All right. How does this compare to the swallow camera technique? I think it's called the Scott cap, where you swallow this tiny camera about the
Yeah.
size of a big vitamin pill, and it travels down the gastrointestinal tract and takes a movie of your intestines and colon.
Yeah, so we have small bowel capsule endoscopy and large bowel capsule endoscopy. And I think we're all fascinated by what these videos show of things in the small intestine and large intestine. The reality is, though, is that we could do the colon capsule. It's not prime time for us, actually. It's been years that it's been discussed, but we have never implemented it, even in my academic institutions I'm a part of. Unfortunately, what happens is if you see anything, you need to do a colonoscopy anyway. So it's
Right.
actually really not that helpful because it's the same as doing an imaging study like a CAT scan or some type of X-ray, which have both have fallen out of favor. I mean, barium enema used to be something we used for colon cancer screening 30, 40, 50 years ago. And
Right.
now we don't do that ever. So I think those are a thing of the past. And I think colonoscopy and blood-based testing are really a thing of the future. And I don't see any role for colon capsule endoscopy at all in the future.
All right. Dr. Eagle, what is the false negative rate from the clinical trials? And you can talk about other data that you got from testing the Shield test. In other words, how reliable is it? Can it miss some cases of colon cancer, or does it depend how advanced the colon cancer is? For example, will it pick up a polyp that's going to become a cancer, or does it have to be stage one or stage two or three?
Yeah, so across all stages, it picks up 83%. But to your point, there is a distinction between the different stages. So it picks up the later stages with 100% in the study that when it compares against colonoscopy. In the early stage one, it's picking up around about 55 to 65% of cancers. And then when you move to the pre-cancer stage, the polyp stage, it's picking up about 13% of those. And so this actually puts it squarely in range with the 83% overall and the ability to pick up cancer in range with other non-invasive testing, as Dr. Albert mentioned. And so this is using the colonoscopy as the reference standard on the performance of the assay. Having said that, what that means is that out of 100 people that are tested, 17 may actually not have their cancer picked up, but we know it's the early stage of cancer. And so that's an opportunity for that person to continue on with screening, get more testing, and be picked up still at that early stage later on in their screening journey. So that's the performance of the test.
Right. What about the false positive rate? In other words, the test comes out positive or abnormal, and then you do a colonoscopy and there's really nothing there. Does that happen?
Yeah, so similar to all the other non-invasive testing, it's about a specificity is what you're talking about. And we have what's called a 90% specificity, which means 10% have a positive test and the colonoscopy doesn't show any signs of cancer. And so this is similar across the board. So that's 1 in 10 people will go on and potentially have a colonoscopy and have no findings on that colonoscopy.
All right. Well, that's good. At least you have the colonoscopy and you get peace of mind. So
Right.
it's good
Yeah,
to
and
have
the main thing to
test done.
remember, as Dr. Albert mentioned, is it's to get screened. Like if you don't have the screening, then you get 100% of people having cancer and becoming symptomatic. And so this is the key thing: is let's get people screened and use the method that gets them actually sticking to the screening procedures.
Right. Now, Dr. Eagle, can patients have this done at their local internist or family doctor or gastroenterologist, or do they have to go to special academic medical centers since this was just approved a few months ago?
Right. No, so currently they can go to their local doctor. It's prescription only, and it's something that they can talk about with their doctor about colon cancer screening, and the Shield test can certainly be ordered through their doctor.
I see. So the doctor would contact Garden to get the kit and then do the blood test on the patient?
Yeah, so if need be, some doctors and practices and certainly some blood collection centers already have the kits available on hand in their offices. But if it's not available, then yes, you can certainly reach out to Guardant and we can certainly work with the doctor to make it available.
And then the doctor sends the blood test tube to Guardant, and then Guardant does the analysis, and within 2 weeks, the patient gets the answer?
Yes, that's right. So the testing is a very technical, highly specialized test. And so
Right.
the blood sample is shipped to our lab and we run the test in our laboratory and then return the results in that 14-day timeframe.
Do the big testing companies like LabCorp or Quest have this? So, in other words, if a patient goes to their doctor and they don't have the test in their office, can the doctor just write a prescription? Patient goes to LabCorp or Quest and has it done there?
So because this is a very specialized testing requiring very careful procedures, particularly around trying to pick up small amounts of circulating tumor DNA, it needs to be centralized. And so that's why we run it at Guardant's lab. But remember, we're
Right.
talking about a tube of blood that can be collected in any collection center. We're certainly working with lots of blood collection centers so the blood can be taken and then the blood is rapidly shipped to our laboratory where the test is run in our laboratory.
Right. I didn't mean that LabCorp or Quest can do the test in their facility, but
Right.
do they have the kits there to
Right.
get the blood drawn and then ship it to you, or is
Yeah.
that not
Well,
available yet?
at this point in time, we're having discussions with them to try and see if we can make it available within their blood collection facility. So that's part of the rollout since the FDA approval a few months ago.
Right. Takes some time to do that. Uh, Dr. Albert, going back to you, if you have a patient who has a positive test, you mentioned that you tell them they have to have a colonoscopy. If they don't do that, then they're taking a risk that they have colon cancer and it'll spread. I assume most people will then listen to you and have the colonoscopy done.
I've had no pushback or any experience with patients pushing back and not having a colonoscopy based on a test that's over 90% specific. So
Right.
it has not been an issue for us.
Not an issue. That's great to know. Dr. Eagle, how often should people get the Shield blood test? Let's say you're 45, you have it, it's negative. How often should it be repeated?
So similar to other non-invasive testing, we recommend that the test be conducted every 3 years at this point in time.
Yes. Can the Shield test be used to monitor recurrence of colon cancer? Let's say somebody has a Shield test that's positive, they have a colonoscopy, and it shows early cancer, they have surgery to remove it. Can you then do the Shield test maybe every 6 months or a year or at certain
Yeah.
time interval to see if the cancer is growing back?
So at the moment, we recommend certainly the technology of looking at DNA in the blood is worth monitoring cancer in that setting you talk about. However, we have designed a specific test that's tissue-free that is able to monitor people that have been diagnosed and treated with cancer. And so that's the test we would recommend that people have. But it's the same concept, tracking that level of cancer DNA in the blood using a test designed specifically for people who've completed treating their cancer,
I see.
and now you're monitoring their cancer in the setting.
So it's not the Shield test again, but you have a different blood test that's used for monitoring.
That's right. So that test is called Reveal, and as I mentioned, it's a tissue-free monitoring test, which means again you just have the blood test to monitor at the molecular level, at the DNA level, if there's any persisting cancer in the body after you're completing treatment, and if that level of molecular cancer detection is changing over time. So this is the way we address that particular situation.
Oh, that's really important to make sure there's no
Right.
recurrences. What's the future, do you think, for other liquid biopsies and precision and oncology at Guardant? What other cancers now have the Shield type of blood test available?
Yeah, so there's two angles to that. The first and foremost is Shield at the moment is focusing on colorectal cancer. The concept of detecting colorectal cancer derived DNA in the blood can now be applied to other cancers. So at the moment, we're running trials looking at people who are heavy smokers who are recommended to have cancer screening, and we're developing the technology based on the same platform for screening in smokers for lung cancer. And then subsequent, there's other cancers beyond that we're looking at. Then you can move to the other area and say, at the moment, we're focused on, for the precision treatment side, we're focused on genomic or genetic mutations. However, we know that cancer taps into the entire genetic makeup has available, as I mentioned, with expression of different genes, what we call epigenetics or methylation. And so now we're looking at how to interpret and read a deeper set of information that gets into what we call the epigenetic side. And this enables us to now look at the various switches and other things that may not be mutated, but have a very key influence on the different cancers. So all in all, we're heading in the direction of creating more and more opportunity to understand the cancer, depending on the stage of cancer that we're looking at and the type of cancer we're looking at.
Right. What about prostate cancer, for example? There's a big dispute about whether to do the PSA blood test or not, because there's a lot of false positives, lead to sometimes unnecessary biopsies or even surgery. It would be nice if you had a liquid biopsy or blood test that would pick up prostate cancer. Are you working on that?
We are working on looking at prostate cancer as a way. How can this technology add value and add information to, for example, prostate cancer? And we talk about adding value, and it's a bit like the Shield test, where we're adding in a choice for people to get screened that has a different choice that makes people feel like I can choose now between the icky stool test or the colonoscopy or a blood test. And same in prostate cancer. You mentioned PSA. How will a blood test work in that PSA? So we are working in prostate cancer to look at how the blood test would fit into the current prostate cancer paradigm.
Yeah, that would be nice because you can have an elevated PSA and then that winds up with a biopsy. But maybe if you had a liquid biopsy blood test, if that was negative, then you might hold off on a biopsy. Whereas if it's positive, then you really need to get the biopsy. So that would be great. Um, Breast cancer, of course, mammographies are recommended for screening and early pickup. Are you also working on any breast cancer liquid biopsies? Because we've mentioned now the four most common cancers.
Yeah, so with breast cancer, again, it's about fitting the paradigm. So we know that women are very compliant, adherent to the breast cancer screening mammography. And so it's a case of, if we bring along a blood test, how does that enhance and support? And so we are assessing the technology in breast cancer. However, it's slightly different to colon cancer, where the screening in women with breast cancer, the rates are very high with mammography. And whilst it also has its unpleasant side to the procedures, the good news is that many people are being screened. Unlike colon cancer, where, as I mentioned, 60% of people are screened, we're missing 40%. We've got the second leading cause of cancer death. And so there's a great opportunity to enhance the screening through the blood test. So we're looking at both, but again, just recognizing it's how we fit in the paradigm of screening that is also a very important piece.
Right. Are there any other cancers that I haven't mentioned that you're currently working on for or testing for early diagnosis?
Yeah, so we're looking at many different cancers. We're looking at ones that are the upper GI ones, so gastroesophageal. We're even looking at data around head and neck, for example, cancers. We're looking at bladder cancer and genitourinary cancers, prostate you mentioned, as well as then looking at cancers like liver cancer, pancreatic cancer. So all these cancers are amenable to the concept of circulating DNA, and we certainly have looked at early data in those. And that's an area that we continue to focus and drive, is how to pick these cancers up early, because that, again, that early detection at the early stages often results in a better outcome in many cases. And the other cancers, of course, the gynecological cancers, ovarian and uterine, etc., are also other areas that we're focused on, along with renal.
Dr. Albert, do you find patients coming to you now asking you about the Shield test because they've heard about it or read about it? Or is it something that you're telling them about and they're not aware of it yet?
No, there was actually a lot of buzz, especially around primary care providers, around the new FDA approval of the Shield test. So I think there's a lot of buzz going on around this new test that almost would prevent the colonoscopy in some people. And so I gladly support it. I think people are excited about it. They're looking forward to it, and yeah, only good things. So no, it's a very exciting time.
Yeah, that's great. So I've learned a lot from this, and I'm going to be telling my patients about it because I do have many patients who tell me they just don't want to do the colonoscopy, which is not a good thing. So I appreciate both of you taking time from your busy day to talk about colon cancer, which is a big problem, and this new, really amazing Shield blood test, which is going to help a lot of people. So thank you very much.
Thank you.
Thank you.